If you would like to put your videos on, that would be great, because these are smaller sessions and, we can have proper conversations, and it's lovely to be able to see people's faces. So welcome to this afternoon's session on developing partnerships of equals, and looking particularly at the experience of Leicestershire and Rutland. And it's great to see you here. The Health Creation Alliance has done a small piece of work with LLR on this and sort of related themes. But I don't want to take away from the great work that LLR have done, because that's the huge part of this. So I'm not going to say anything really about that, and I'm sure some of that will come out of this session. We only have 20 minutes, so it's a quick session, and we've got quite a lot to get through. So I'm going to introduce our first speaker, who is one of the community connectors, and you're very welcome to join us here today, Kaval Sachdev, who works for the South Asian Health Action, and is one of the connectors in this programme. So, Kaval, you have a story to tell from lived experience. And we're going to start with you. Then we're going to move to Raj to come on to some of the sort of thinking that's being done by the systems people. And then back to Bina just for a few minutes to look at what the connector sort of ambitions are. And then we'll have a discussion. So there'll be time for discussion then. So without further ado, Kaval, do you want to just tell people on this call a little bit about your experience of the health system from your perspective?
Yeah, it's been quite a long and strenuous journey. It started a few years ago, maybe 3 to 4 years ago. I was struggling to register with a GP, just couldn't get even registration. This is my local GP, which I'd moved back to Leicester recently. Was trying to get an appointment to get a lump checked out, but they just wouldn't get me registered. February 2022, I went into hospital. This was stress-induced. My body had mimicked a heart attack. Apparently, it was a stress-induced heart attack. My body had mimicked it, and also my LCV had torn. It created a blood clot, which was approximately just under a centimetre away from my heart, which could have been fatal at the time. I'd got into hospital. I was experiencing pain, so I'd gone straight to hospital. This was February 1st, 2022, and when I got there, went through the process. They checked everything. I had high levels of troponin at the time. I was put straight into the emergency care at Glenfield, the cardiovascular side. From Royal Infirmary, they transferred me to Glenfield on that day. And they asked me about any other symptoms or anything else that had happened. And I showed them the lump, which was in my pelvic area. And I said, obviously, I've been trying to report this for a while now, at least about 2-3 months, but I've just not been able to get registered. They said, this has got nothing to do with the situation that you're in hospital for, so we will deal with that, but we've got an emergency situation to deal with. So after that, they were dealing with the emergency at the time, which was the cardiovascular side. On the first day that I was there, I was told, on the second day, after they'd done the emergency checks, overnight, I'd stayed. The next day, they told me that there was probably a 80% chance I'm not going to leave the hospital, so to call my parents, my family, speak to them, and also that I would need stents. And the way that was explained was very forceful. The tone of voice, it was a case of, you need these stents, you need to sign this form, and you need to give us permission so we can get it done. And at that time, the reasons I was being explained why I needed the stent, I don't believe I needed. I didn't sign the form, and I felt like I needed a second opinion. It was just the way that it was delivered to me. It was just really forceful. The tone of voice, the delivery. You'd have to hear it to understand what I'm trying to say. Anyway, after that, it turns out that I didn't need stents in my body, and had I signed that form, it potentially could have caused more danger to myself. My arteries and everything were actually okay. The heart attack was a mimicked heart attack, and the reason I was getting the chest pains as well was because of the blood clot as well, and that was done through an angiogram when they put the camera up your vein. So once they saw the blood clot, everything, they realized that, okay, there is space in the arteries and everything. He doesn't need a stent, and it's actually just a blood clot. So that was all sorted out at hospital. I was on blood thinners, was given medication, and, touch wood, survived all of that. I was still chasing up. So during that hospital stay, I'd advised them about the lump, 2-3 times. Obviously, that first day when they'd asked me, and then during the course of the 2-3 weeks that I'd stayed there after that, I'd advised a few of the specialists and consultants as the days progressed that, I've still got this lump. So it was noted a few times during my hospital stay. I came out, I was due to go to the GP regularly, explained to them about the lump. They'd noted it. This is, now we're talking from that February-March period, and it got to end of August before my biopsy was done. And then in September, they diagnosed me with an aggressive cancer and said I should have told them earlier about the lump. And had they have seen it, maybe weeks, months earlier, it might not have got to that aggressive stage, and potentially I wouldn't have had to have the treatment that I've had to have, which has been chemotherapy, GCSF, steroids, various injections. It's just been, and I don't know, had they have caught it 7 months earlier, whether things would have been. Is too hard to say now. But the fact is that that was their opinion on it, from a professional point of view. That had they have seen it 7 months earlier, it would have more than likely been caught at an earlier stage. Then, actually, when I was diagnosed, and I said to them that, I did tell you, that they said, no, you haven't. Looked at my records, and it's written there in black and white in my hospital records from my hospital stay. And also then afterwards, when they checked with the GP notes, it was there as well.
Thank you, Kaval. Yeah. So thank you for coming and telling us that, because I know that your treatment is ongoing, and you're not out of the woods yet. And it's an effort that you've made to come here to talk to us. So thank you for that. And talking to you earlier and now, the things I'm picking out of this are the kind of a feeling, at least, whether it's true or not, but a feeling of not having been kind of listened to, and of the sort of power dynamic between the professionals and experts and you as a patient. And these are some of the things that we're trying to sort of deal with and change through this program, so that actually patients and communities and people, when they're not in medical environments, so that the relationship works differently between the clinicians and system, and between yourself and others like you. So bearing in mind that's just one person's experience, I'll come to Raj now, and because I know, Raj, you came to the sessions and you've been an activist here, and Raj is the primary care lead for health inequalities at University Hospital in Leicester, and clinical lead. So I just wondered if you wanted to say a few words about kind of, not specifically this case, because obviously there's a big clinical background to it, but of some of those dynamics and how you're working in LLR to try and shift those.
Yeah, thanks, Maron. Sorry to hear about those, Kaval. Certainly, it's not a nice thing what happened to you, and could have been perhaps better as well. So it is. I won't go into clinical details because that requires a bit of that more clinical context and things. But overall, I'll be surprised if there's any doctor or any clinician who doesn't want to work with the patients. Yeah, I think there are barriers to that which we need to overcome. That's the main thing about it, to be honest. Yeah, everyone has got the right intention and the right like will to do it, but there are some barriers that we have to overcome. And then good news is, like, we have recognized those barriers more than usual, more than before. Yeah, since this health quality has been shown light since the post-COVID and with some Moss report, and then going on with the literatures, and the ICB has become very aware of the health qualities, and have made it a very like a center of focus for the last few years in that way. Yeah, and as you know, Maran, that's the reason that that we led up to the setting up of the connector program in LLR ICB as well. We have a very well established connector programs, and which represent our population very well, the diverse population of the whole of the LLR. And so that's a good thing that we have stepped into it. But like we discussed in the previous sessions of the connector program, we're still still a way to go, actually, like to get into that proper action and proper connecting with the community, and then also not only at the large community level, but also at the individual practice level, and then individual consultation level, like Kaval mentioned. Yeah, and to come down to that level of like connection with the patients and the clinicians, and so that you feel of like patients are involved in the decision making appropriately with them, and patients are well informed, yeah, in that. So the basic thing about the treatment is like you need expert, okay, you need a knowledge clinicians, but also you need a well informed patient, and to work together to come out to get the outcomes. Yeah, so that's so otherwise, if one is not happening, the other one, if like will not work. Yeah. So I think we the connected program is the first step, but I think the main thing also is like about that about this kind of taking out that barriers between the clinician and the patients, yeah, in the at the practice level. So like I mentioned before, that a lot of clinicians like are not that keen to like go and speak at PBGs, and they get shy away from it, and the for the various things, yeah, in that way. And the it's not that the intention is not there. Intention is there when I did it in a practice, like one of like speaking to my PPG or speaking to my practice, to my patients about the difficulties that we are going through as a clinicians in the NHS in the system, and then the how resource about the resources, about the workforce, and about that what we're trying to do, and the all those things. The patient, the reaction was like, "Doctor, you should have told us beforehand all these things. We are not aware." Yeah, and then we could have actually like help you like in your like a whole of this, like trying to improve our quality of the whole of the services. So to be honest, the silent things about between clinician and the patient that need to be broken, and we need to talk more about the individual problems, like Kaval has done for his problems, and then doctors talking about the clinicians talking about their issues, and they're all like very openly like to each other, so that we trying to connect to resolve the problems and resolve the solutions together. Yeah, and the system will always have a problems, like, but it doesn't mean that we can't do it ourselves at the individual level and the practice level to come up with some solutions. I think there are some good examples already for that as well, which can be expanded if you want to talk about it and things like that. We can expand on examples, but that's the overall gist that I just want to say.
Yeah, that would be great, actually, if you could expand. I mean, one of the things we came up with through the sessions was for that session to be continued and become a regular sharing platform. So the clinicians and the connectors can get together regularly outside of the PPGs where there might be history. And this could be a new way. We also, I think, I mean, it'd be interesting to see what you think, but we talked about the fact that the people making the sort of funding decisions to do with sustainability are not the ones seeing it working. So that could be a platform for that as well. I think another one was about, that you mentioned as well, Raj, was about working together to make a business case for resources, to work together on things and to build the connectors in at the start. Are these some of the things that you were going to mention? And do you want to just
Yes,
elaborate?
those are typical areas. So what we are trying is like in the ICB, definitely now health quality is one of the major scoring criteria for any funding. Yeah, in that way. So we got the what we call the system prioritization score framework, which which services and which should be funded or commissioned. Health quality is like a very high score in that, actually. Like, so every paper, everything like business cases coming through has to have an impact on the health quality assessment. Yeah, it has to be done, and then with the scoring system in that area. So that's quite good. And then on top of that, what we want to see is like is the not getting in the connectors later on in the later stage, but having a connectors presentation at the point of designing the services. Yeah, like a co-design where like the allocate resource allocations is also included for connectors. Yeah, in that way, and then how the connectors will act and how the connectors will contribute, yeah, to this program, or what resources should be like allocated for that from the start, so that when we do a business case, it's already in there, and then so that I can understand that when you're giving your time and the things to do it, that should have appropriately resourced for everyone. Yeah,
Yeah.
and the last minute calling in to engage, then you don't get that like a full engagement that we would like to have. Yeah, so and we can't just rely on the goodwill forever as well. So I think
Yeah.
those changes we're trying to make it like more co-productions, more co-designs from the start, yeah, not only for funding but also like understanding those problems happening at grassroots, yeah, and then
Yeah.
and getting the engagement
Yeah.
better from the grassroots
Yeah.
as well. So, yeah.
That's great. So you're looking towards getting to a point where, you know, the system and clinicians are working with the connectors on everything really, and you think about each other, and that grows, that relationship grows. And I know we spoke at one of the sessions about myth busting and how the clinician being with the connector can help to give that connector credibility that they really do know what they're talking about when it comes to cancer, and that kind of thing. And I love that reciprocity, that we were finding ways through, you know, of sort of what are the win-wins, how can we reduce that power dynamic to being equal, and that was really coming through. So there's another couple of things there as well. Bina, just coming to you, and then we'll just maybe pick up one or two questions before we go. But what do you think the connector ambitions are for, you know, for this program going forward in terms of the power dynamic and the relationship?
I think for definitely a lot of the connectors that have fed back, the whole journey for them has been very kind of inspiring and motivating and very healing for them as well, in terms of the kind of involvement. When we've done events like around cancer events, and you know, a fashion show which had like clinicians there from the NHS around cancer, talking about all of that. And the connectors, they're there to like support that information to come across to the audience much engaging, so as to speak, because that lived experience certainly helps them to build and connect with that individual, so they're more engaged and they take it on board as to what needs to happen or what can they do in terms of their kind of health and well-being, empowering them. I think connectors need to be part of all of this, and I think Dr. Raj just mentioned it, or they need to be involved from the beginning. They need to be embedded. They are very passionate, as Keval also mentioned. The message comes so much more better when it comes from them. And I think clinicians are very good in terms of, they know the medical, they understand terminology, but it's a lived experience, that individual who can actually reassure somebody. And I feel the connection needs to be there, the joining up, the bridging needs to be there. In terms of sustainability, I also know that connectors are struggling, so the cost of living is affecting them. It'd be nice if they could be remunerated, they could be paid. In terms of that, it also not only gives them something, but if they're embedded within this whole system, they're also taken a little bit more serious by clinicians as well. So they are naturally being involved throughout the process, from the beginning to the end. And I think that's really, really important as well. I feel also clinicians equally, they're very somewhere in a different world, so as to speak. It'd be nice if there were more within the community venues. It'd be nice to see if the important kind of meetings that do take place within the ICB, etc., if they were within the community, with connectors potentially being involved as well. And, you know, once it's in the community, the community feels they're a part of that as well, because ultimately that is what I understand the NHS to be. It's very much for the community, designed for, you know, to treat people with illnesses.
Lovely, thank you, Bina. And I think it's important to say, isn't it, that equal partnerships doesn't mean the same. It means you're each playing roles and actually being valued and hopefully at some point remunerated for that as well. And that's, you know, one of the questions around sustainability, isn't it? Just sort of one final thought, which I know came up in one of our sessions, is about workforce allies. And you know, Raj and Roo, who's another clinician, very much allies of this program. But how, the question I think is, how do they get that the connector program kind of embedded and offer that system's validity? How do we get it back into the system so that it can change the system and get that sustainability built in? So I'm going to open it up for questions now. I think we've still got a minute or two. If anyone has their hand up or wants to just shout out at this stage, please do. Or points to make. Doesn't have to be questions. Anything that resonates with you, anything that's popped out there? Nope. So we've got 54 seconds left. So please do shout up if you want to. There is opportunity. I'm not going to say anything else from now because I want you to be able to have that space.
Yeah, I just added on to that is from the LLR is like connector program is coming in shape like in the vaccinations we have like shown it like how effective that could be for sustainability of the equal uptake or equalizing the uptake among the hard to reach underserved populations. Yeah, and then some of the cancer screening program, Mark has been instrumental, and then so in this kind of like how do we connect with the connectors to get that screening program in the low uptake areas. So so that kind of examples have shown that actually it works quite well if we are